A very good afternoon to one and all. I am here presenting residual resorption and its postmortem management. This is the table of content. Introduction, bone microscopy, classification of bone, pathology, pathogenesis, epidemiology, etiology, management, summary, and conclusion. So what is bone? Bone is highly vascularized, living, constantly changing, mineralized connective tissue. Alveolar bone. Alveolar bone is that bony portion of maxilla or mandible in which the root of the teeth were held by the fibers of the periodontal ligament. Residual alveolar ridge. The portion of the alveolar ridge and its soft tissue covering which remains following the tooth removal or extraction. Residual ridge resorption. A term which is used for the diminishing quality and quantity of residual ridge after the teeth being removed. It is known as the residual ridge resorption. Now coming to the microscopy of bone. Bones are either long or flat and have outer compact bone, inner medullary bone, which is also known as trabeculae, cancellous, spongy at the ends. This is the microscopic structure showing the unit of bone, that is osteon, and different other structures such as Haversian canals, interstitial lamellae, etc. The microscopic layers of bone shows three types of layers, which includes circumferential layer that encloses the entire bone at the perimeter, the concentric layer which forms the bulk of the compact bone and of the osteum, and interstitial lamellae which spreads in between the concentric lamella to fill in the spaces. This is another figure showing the same structure which I mentioned. So what is osteon? Osteon is the basic metabolic unit which is cylindrical or long in structure of the bone. Osteon is the basic unit of bone which is cylindrical and or the long towards the long axis of the bone. Haversian canal. Canal in the center of each osteon enclosing a capillary is known as the Haversian canal. What is periosteum? Periosteum is periosteum is the part which surrounds the outer aspect of every compact bone having two layers. One is the fibrous, other is the cellular. The fibrous layer consists of dense, irregular connective tissue, and the cellular layer is the inner next to the bone surface having bone cells. What is endosteum? Endosteum loosely demarcate the cellular membrane containing the loose connective tissue. Bone cells. What types of bone cells are there? Osteoblast. They are the bone forming cells, cuboidal or flatter, that lay down the collagen matrix as scaffold for the mineralization of bone. Osteocytes. Osteoblasts trapped in the scaffold have numerous processes to communicate and signal bone metabolic changes. Osteoclasts. They are large, multinucleated bone resorbing cells, irregular and ruffled active border present in these cells and in the bone cavity known as Hauschilp's lacunae. This is the structure showing the Haversian canal, canaliculi, and the osteocytes lacunae. So what is the mechanism of bone resorption? Bone resorption usually occurs in two stages. Initially, the mineral phase is removed, that is, the mineralization of bone is gradually diminishing or gets stopped, and in the later stages, the organic phase is removed. Creation of acidic environment which dissolves the mineral crystals of bone, followed by degradation of the organic matrix by neutral matrix, metalloproteinases, and cystinic proteinases. These are the procedures by which diminution of bone takes place. As the resorption takes place, the osteocytes, the bone forming cells released, may revert to osteoblast or become osteoclast. The bone forming cells becomes the bone scavengers, depending on the physiological and pathological demands. Histologically, bone apposition and resorption takes place in close approximation. The formation of bone and resorption of bone takes place in close approximation, making possible to the bone balance and shape and size. This makes an homogeneous equilibrium with the bone forming and bone resorption. It maintains the shape and the size of the bone. So according to Brenmark et al., the quality of bone is classified into 5 classes: A, B, C, D, E. Class A demarcates the most of the alveolar bone. Class B demarcates the moderate residual ridge resorption. Class C tells advanced level of residual ridge resorption. Type D is moderate resorption with basal bone, and type E suggests extreme resorption of basal bone. This is the classification given by Brenmark with regards to residual ridge resorption. Quality of bone. As per Brenmark, the quality of bone is classified into 4. Class 1, almost the entire jaw is composed of homogeneous compact bone. Class 2, thick layer of compact bone surrounds core of dense trabecular bone. Class 3, thin layer of cortical bone surrounds core of dense trabecular bone. And class 4, thin layer of cortical bone surrounds the core of low density trabecular bone. Another classification given by Wickel and Swoop with regards to the mandible. This is having 3 classes. Class 1, up to 1/3 of the original vertical height is lost. Class 2 says up to 1/3 to 2/3 of the vertical height is lost or resolved. And class 3 says more than 2/3 of the mandibular height is lost. This is the residual resorption with regards to mandible given by Wickel and Swoop. This is also reconfirmed by the help of OPG, estimating the amount of resorption using the Wickel and Swoop method, in which the position of mental foramen is the key to judge this classification. Another classification is Neal's classification, in which there are 3 classes. Class 1 suggests that 0.5 space exists between the mylohyoid ridge and the floor of mouth. Class 2 suggests that the space is less than 0.5, and class 3 says floor of the mouth is as same as the level of mylohyoid ridge. Another classification given by Atwood. This is the most acceptable one. It gives 6 classification. Number 1 is order 1, which is the pre-extraction socket, in which the tooth is seen. Order 2 is the post-extraction. The tooth is removed, but there is a healing socket in this figure. Class 3 is after the healing, but the ridge is high and well rounded. Class 4, the resorption of ridge taking place, but the ridge is looking knife edged. Class 5 is low but well rounded, and class 6 is depressed. So this is the classification given by Atwood. Another classification given by Mish with regards to the bone density, that D1 is the dense cortical bone. D2 means thick, dense to porous cortical on crest and cortical trabecular within. D3, thin porous cortical bone on crest and fine trabecular bone within. D4 is fine trabecular bone, and D5 is immature and non-mineralized bone. Another classification given by American College of Prosthodontic Classification based on the bone height, that is restricted to mandible only. It gives 4 types. Type 1 is the residual bone height of 21 mm or greater, measured at the least vertical height. Type 2, residual bone height of 16 to 20 mm. Type 3 is residual alveolar height of 11 to 15 mm, and type 4 is residual alveolar height of 10 mm or less. So this is only with regards to the mandible. Based on the residual ridge morphology, with regards to maxilla only, type A, anterior labial and posterior buccal depth resist vertical and horizontal movements of the denture base. Palatal morphology resist vertical and horizontal movements of the denture base. Sufficient tuberosity definitions, well-defined hamular notches, absence of tori and exostosis. Type B is the loss of posterior buccal vestibule. Palatal vault morphology resists vertical and horizontal movements of the denture base. Tuberosity and hamular notch poorly defined. Palatal tori or exostosis rounded and do not affect the posterior extension of the denture. Type C, loss of anterior labial vestibule. Palatal vault offers minimal resistance to the vertical and horizontal forces. Hyperplastic mobile anterior ridge offers minimal support and stability. Reduction of post-malar space by coronoid process during mandibular opening excursions. Type D, loss of anterior labial and posterior buccal vestibules. Palatal vault offers minimal resistance. Maxillary palatal tori exostosis interferes with the posterior border of denture. Hyperplastic anterior reductant ridge and prominent anterior nasal spine. So what is the pathology of residual ridge resorption? According to Gross, a layman expressions says my gums have shrunk. Reduction in the size of bony ridge under the periosteum. Overlying mucoperiosteum may or may not be excessive or reductant. Lamy ciatrization of mucoperiosteum seeking reduced area pressure resorption. May progress well below the apices of the teeth. Right bone studies have also shown wide variety of residual shapes and sizes, residual ridge porosities and imperfections. Clinically easy to visualize the ridge form, however, palpation is must. Tracing of 3 lateral cephalograms carefully superimposed over 50 months post extraction. This is the criteria to find the pathology of residual resorption. The microscopic level. Evidences of osteoclastic activity on the external ridge crest is seen. Scalloped margins of Hauschilp's lacunae shows visible osteoclast covered by fibrous non-osteogenic periosteums. No studies to date till date have shown periosteal lamellar bone covering crest of residual alveolar ridge. Mucoperiosteum showing varying degrees of keratinization, acanthosis, edema. Inflammatory cells such as lymphocytes and plasma cells. Pathophysiology. Bone resorption is bone resorption and bone formation. The equilibrium, whenever the equilibrium changes, the resorption takes place immensely. Residual resorption is localized loss of bone. According to Enlow's principle of remodeling, long bone with inverted V principle is the principle to explain the residual ridge resorption. This is it. This figure shows inverted V, the resorption of the ridge taking place at the outside of the ridge, whereas in the other structure, Enlow's V principle, the formation of bone is taking place. So the inverted V is the demarcation of residual ridge resorption. Bone formation is when the bone formation is equal to the bone resorption, then there is a normal height of alveolar bone. When bone resorption gets somewhat increased, but the bone formation is unaltered, then the resorption takes place, but it is somewhat neutralized. When the things get reversed, bone resorption is unaltered, but bone formation gets decreased. Then the height of the ridge gets reduced and the pathologic bone loss is seen. And the last, bone resorption is increased and bone formation is decreased. There is tremendous loss in the height of the ridge and the residual resorption is seen very rapidly. So what is the pathogenesis? Residual resorption is a chronic, progressive, irreversible, and cumulative procedure which usually occurs after the removal of tooth. This proceeds or flows imperceptibly from one stage to other. Means from this to this, it goes on as soon as the tooth is being removed. Annual incremental bone loss have cumulative effect and no autonomous bone regrowth reported. Many longitudinal cephalometric studies conducted in several countries, and this shows the rate of resorption recorded affected by time since extraction and the length of time over which the rate is recorded. Over the period of 5 years, post-extraction studies of Carlson and Person in 34 subjects, remarkable differences in mean resorption rate have been observed over the different periods. Pattern of given patient established early and followed over 5 year of period. This chart shows the studies being done on 34 subjects, and this shows that the ridge resorption is taking place as soon as the extraction is being done, and it's up to 0.5 mm per year, which is in an average over all the patients 6.8 mm from the date of being extraction is being done. So this is the rapid rate of residual ridge resorption as soon as the teeth being extracted. Another graph showing the same. In other studies, the mean ratio of anterior maxillary to anterior mandibular residual resorption was found to be 1:4. The ratio of mandibular bone resorption is 4 times greater than the ratio of resorption of maxilla. On an average, residual resorption is greater in mandible than in maxilla. The reverse may also be true. Treat the particular patient, not the average patient. Changes in the maxilla and mandible during the phenomena of residual resorption. What takes place? Maxillary teeth are generally directed downwards and outwards. So bone reduction generally upwards and inwards. Since the outer cortical plate is thinner and the inner cortical plate than the inner cortical plate, resorption from the outer cortex tends to be greater and more rapid. As the maxilla becomes smaller in all dimensions, the denture bearing area, basal sheet becomes decreases. The basal sheet area decreases. The bone of the maxillae resorbs primarily from occlusal surface and from buccal and labial surface. Thus, the maxillary residual ridge loses height and maxillary arch becomes narrow from side to side and shorter antero-posteriorly. This figure shows the pattern of maxillary residual ridge resorption. The anterior maxillary teeth generally inclines upwards and forwards to the occlusal plane, whereas the posterior are either vertical or inclined slightly lingual. The mandibular ridge resorbs primarily from the occlusal surface because the mandible is wider at its inferior border than the residual ridge, alveolar ridge in the posterior part of the mouth. Resorption in effect moves the left and right ridges progressively farther apart. This is the pattern of mandibular ridge resorption. A progressive resorption of maxillary and mandibular arches showing the maxilla getting narrower and the mandible is getting wider. The lines A and B are suggestive of this remarkable procedure. The mandibular arch appears to become wider while the maxillary arch becomes narrower. Thus, the residual ridge resorption in centripetal is centripetal in maxilla and centrifugal in mandible. The surface of the arches may be resorbed out of parallelism, which can result in diminished stability of dentures. Severe ridge resorption can also result in increased inter-arch spaces. So what is the epidemiology of residual ridge resorption? Till date, it would appear that residual ridge resorption is worldwide, seen everywhere in the world, occurs in males and females, young and old. Sickness and in health, either you are healthy or you are sick, this procedure is going to happen with and without dentures and is unrelated to primary reason for the extraction of the teeth, caries, either due to caries or periodontal disease. So the rate of residual resorption is variable. What is the variable? It is different in between different persons, within the same person at different times, within the same person at different sites. It may vary from person to person. It may vary from this in the same patient at different sites. It within the same patient at different times of life. So this is the different variables related with residual resorption. So what is the difficulty in studying residual resorption? What is the difficulty in studying this criteria? Disease is almost universal, as I mentioned earlier, but varies in amount and rate. The rate of resorption and the amount of resorption is varies in different patients. Cumulative effects, so single examination does not reveal any present rate. The resorption takes place cumulatively, so one can't assess the situation in single examination of the clinical examination of the patient. So it needs a longer duration of studies and longer regular checkups of the patients. Lengthy longitudinal study is needed as the rate is slow. Rate may vary at different times, different sites in the same individual, depends upon the complex interactions of several factors, all not easily measurable. So what is the etiology? Etiology is multifactorial biomechanical disease resulting from combination of anatomic, mechanical or metabolic factors. Anatomic factors, metabolic factors, functional factors, prosthetic factors. These may be the etiology of residual resorption. So these three are the major etiological factors. They are anatomic, biological, and mechanical factors. These factors vary between patients and may combine in infinite ways to cause this criteria of residual resorption. Each factor will be dealt in isolation, and then all factors are combined together. So, anatomic factor. It is postulated that residual ridge resorption varies with the quantity and quality of the bone of the residual ridge. Residual resorption is directly proportional to the anatomic factors. The amount of bone, it is not good prognostic factor for the rate of residual resorption because it has been seen that some large ridge resorbs rapidly and some knife edge ridge may remain with little changes after longer duration of time. Although the broad ridge may have a greater potential of bone loss, the rate of vertical loss may actually be slower than that of the small ridge because there is more bone to be resorbed per unit of time, and because that the rate of resorption also depends on the density of the bone. Next is the quality of bone. On theoretic grounds, the denser the bone, the slower the rate of resorption because there is more bone to be resorbed per unit of time. Metabolic factors. Residual resorption depends on the formation, the resorption factor and the formation factor. If this equilibrium changes, the resorption will take place rapidly. Local bone forming factors including endotoxins from dental plaque, local bone resorbing factors including endotoxins from dental plaque, osteoclastic activity, prostaglandins, human gingival resorption stimulating factors, systemic factors. Local resorptive factors work in a systemic environment. Bailink et al. Stated that bone loss due to systemic cause occurs in three ways. Bone loss due to decreased formation, the bone which is lost due to the decreased formation of bone, the bone loss due to the increased resorption, and the bone loss due to the unknown causes, that is idiopathic. The bone loss caused due to the decreased formation. This suggests that the excess amount of glucocorticoid hormone which inhibits the bone formation, that is, it suppresses the calcium absorption. This may be due to excess secretion of cortisol by adrenal glands, which is seen in Cushing syndrome. Treatment of autoimmune disease, example rheumatoid arthritis with excessive glucocorticoids. Bone loss due to the increased resorption. Hypophosphatemia. This says that this enhances the synthesis of 1 to 5 dihydroxycholecalciferol, active metabolite of vitamin D, which stimulates the formation of which stimulates the bone resorption. Hypophosphatemia rarely occurs due to phosphorus deficiency. May occur in duodenal ulcer patients treated with antacid containing aluminum hydroxide gel, which binds phosphorus and renders it to become unabsorbable. May also occur in patients with impairment of renal tubular absorption of phosphorus. High parathyroid hormone. Normally, the parathyroid secretion is controlled by the serum calcium by negative feedback mechanism. The decreased level of calcium stimulates the parathyroid secretion, bone resorption starts taking place, renal absorption of calcium becomes higher, restoring of calcium and balancing the becomes difficult, and this goes on with a loop. Primary hyperparathyroidism, abnormal increased function, increased resorption. Secondary hyperparathyroidism, normal gland function but excess parathyroid secretion due to fall on calcium levels and attempt to restore the calcium balance. Secondary hyperparathyroidism, it includes the low calcium intake. The patient is unable to incorporate the calcium diets. Poor calcium absorption, the patient is unable to absorb the calcium by either the growing age, small bowel disease, liver disease, or the partial gastrectomy, pregnancy and lactation, and in renal diseases. All these factors includes the estrogen and androgen deficiencies, increased osteoporosis following surgical, normal menopause in women. Estrogen has parathyroid antagonist effect. Androgen deficiency also causes bone density to reduce and mechanism less studied. Calcitonin deficiency produced in thyroid gland and inhibits bone resorption. However, the post-thyroidectomy patients do not show clinical significance of osteoporosis. Bone loss due to unknown causes, that is age-related bone loss, decreased physical activity. As the age progresses, the patient is unable to move swiftly because there is not so much energy in the body. So the patient is less physically active. Decreased estrogen secretion after 40 years, among other unknown factors. Genetic factors. Blacks have higher bone density and less age-related bone loss than whites. This is a comparison of individuals with regards to genetics. Clinical significant osteoporosis is more common in short, light-weighted females than tall, heavy females. This is with regards to the body height. Prosthetic factors. Excessive stress resulting from artificial environment. Human tissue have not evolved in nature to accept ranges of artificial things, and denture acts as an artificial entity. Abuse of tissue from lack of rest. Tissue abuse also manifest this situation. Abused tissue are always manifested with a slung, glistering surface. Bone is moldable. It can tolerate masticatory forces within the limit of physiological tolerance, but exceeding these forces may cause damaging results, which result in resorption of alveolar bone and alteration in the form of the tissue as well. Long continued use of ill-fitting dentures. In ill-fitting dentures, there is an improper relation of denture base to the supporting tissue, that is the intaglio surface of the denture. Ill-fitting denture may also be due to longer use, loss of bone, incorrect occlusion, or incorrect jaw relation. Underextended dentures. These lead to less retentive dentures and increased load per unit area of the denture bearing tissue. The commonest sites are lingual flange, buccal shelf area, retromyahylate ridge, and retromolar pad. Faulty improper procedures employing compression forces. Before impression procedures, care has to be taken on the selection of trace. If the trace selected is too large, it will distort the tissue around the borders of the impression away from the tissue. If it is too small, the border of the tissue will collapse inwards onto the ridge. This will reduce the support of the lip by the denture flange. The use of minimal and selective pressure impression technique should be implicated in order to avoid distortion of the mucosa and ridge area, which may under considerable pressure otherwise, Error in relating maxilla to cranial landmarks, that is the orientation relation. The plane of maxilla should be oriented to the facial reference line, that is the campus plane or the ala tragus line. If not, may cause instability of denture leading to the resorption. Lack of the freeway space due to the increased vertical dimension of the occlusion. Freeway space is present in the teeth in the physiologic rest position. It is normally 2 to 8 millimeters, but in complete denture, it is around 2 mm. At times, due to lack of freeway space, the bone resorption becomes increased because of bone resorption gets bone resorbs due to increased vertical height. Incorrect centric records. If the centric relation is not recorded properly, the mandibular teeth will not occlude properly with those on the maxillary arch. This proper occlusion is essential for the health of boning support underlying the denture. During eccentric movements, it causes pressure on the bone due to failure of denture stability. Hence, resorption of the base occurs tremendously. Faults in the selection and placement of the posterior teeth. The selection of proper tooth size is based on capacity of ridge to receive the resistance of the forces of mastication and spaces available for the teeth. When the ridge is weak, resorbed and covered by only lining mucosa, then the use of posterior teeth should be smaller. This will limit the occlusal surface, which in turn will minimize the forces directed to the ridge. If the occlusal corrections are not done, these errors may be due to the processing techniques, if not correctly done, causes premature contacts resulting in increased stresses on the underlying bony surfaces. Selective grinding should be done to minimize the lateral stresses and resulting in the tissue trauma. Overclosure. The loss of proper vertical dimension after the insertion of complete dentures results in the triggering of cyclic series of events. These are detrimental to the health of the residual alveolar ridge. Overclosure causes the mandible to be moved and rotated in an upward and forward direction, causing occlusal disharmony and excessive trauma to the anterior ridge. Bone resorption and calcium homeostasis. The only source of calcium for the body are diet or the bone reservoir. Calcium homeostasis is maintained by controlling the calcium obtained from these two sources. This can occur by altering internal absorption mechanism, that is the incoming or the trabecular resorption, that is recycling, or the liberation of calcium from the skeleton via resorption, that is the saving. These are the only sources of calcium in the body. There is a reciprocal relationship between calcium concentration and bone resorption to maintain the calcium homeostasis. As the level of serum calcium decreases, resorption is stimulated and factors that would inhibit resorption are depressed. Skeletal depletion of calcium occurs as a result of stimulation of parathyroid gland, and the alveolar bone is the first to be affected by this phenomena. This is due to the function of parathyroid hormone is in the maintaining of blood calcium level by mobilizing the bone by osteoclastic activity. Simultaneously, there is an increased renal excretion of phosphate, which disturbs the blood calcium phosphorus ratio by raising the blood calcium level. This results in mobilization of phosphates from bone to osteoclastic activity. Under these conditions, the alveolar bone becomes susceptible to disease like osteoporosis. So osteoporosis and residual resorption are somewhat correlated with each other. Osteoporosis is a characterized disease by low bone mass and microarchitectural deterioration of the bone, which leads to the increased bone fragility and risk of fractures. It has two forms. First, type 1 is postmenopausal. It is the most prevalent, affects women for a decade or so after menopause. And type 2, that is the senile or idiopathic, attacks male and females at any age, but obviously for no reason. Residual resorption may be a manifestation of type 1 osteoporosis. Both cortical and trabecular bone are being affected by this phenomenon. Treatment of osteoporosis. Estrogen replacement therapy is the usual treatment given, along with some calcium supplements. Good nutrition and regular exercise is advised. New drugs for systemic osteoporosis and under evaluation, including biophosphonates to inhibit the osteoclast and calcitonin to reduce resorption. So what is the management of residual resorption? First, systemic evaluation, diet, tissue treatment therapy, pre-prosthetic surgeries. Post-prosthetic management includes impression technique, denture-based selection, teeth selection, arrangement, implant prosthesis, supported prosthesis, etc. First of all, systemic evaluation. Any systemic condition that can contribute to the degeneration of the bone condition should be corrected and stabilized. For example, osteoporosis, hyperparathyroidism, diabetes mellitus. Any dental treatment should follow only after the condition is under control and the patient is fit for treatment. In cases where limited help can be given, the patient should be counseled about its effect on the dental health. Diet. Patient with bone diseases need a diet high in protein, vitamin, and mineral content. Should reduce or stop the intake of refined carbohydrates, white flour, and white sugar. In all dietary prescriptions, the consistency of food prescribed must take into account that the patient's ability to masticate. Tissue treatment therapy. Soft conditioning material can be used to rejuvenate the tissue bearing area. Hypertrophied tissue previously treated by surgeries can be reconditioned by using this material. Pre-prosthetic surgeries. It aim at providing a good healthy surface for the insertion of dentures. It is the preparatory stage before fabrication of the denture. Any situation which is unfavorable for the fabrication of denture should be eradicated before the starting the procedure. It includes all the surgeries by virtue of which an ideal, smooth, healthy, U-shaped ridge without any unfavorable undercuts, bony outgrowths, and sufficient vestibular depth is being achieved. It includes the following surgical procedures, usually ridge corrections, ridge extensions, vestibuloplasty, ridge augmentations, surgical correction of maxillary mandibular relationships are the pre-prosthetic surgeries being done. Ridge corrective surgeries includes soft tissue deformities such as labial frenectomy, lingual frenectomy, high buccal frenal attachments, hyperplasia of soft tissue. Bony deformities includes sharp irregular ridges which are rectified by alveoloplasty, alveolectomy, excision of tori and genial tubercles. This is not an ideal condition for fabrication of denture, so some correction of the knife edge ridge has to be done so as to get a high and well-rounded denture alveolar ridge for the dentures. Same with this alveoloplasty, genial tubercle is being excised so as to provide a proper denture bearing area. Ridge extension or vestibuloplasty. This is done usually at the site of labial vestibuloplasty, lingual, high mental foramen, zygomatoplasty, and tuberculoplasty. Ridge augmentation surgeries. Ridge augmentation. It is aimed at why it is done. It is done to increase the height of the ridge. Increase the ridge height and width, providing a large denture bearing area, protection of neurovascular bundles, resorption of proper maxillo, restoration of proper maxillomandibular arch relationship. These are the usually desired aspects of ridge augmentation. Ridge augmentation has been tried with bone transplants, autogenous and homogeneous cartilages, alloplastic materials such as hydroxyapatite. Vertical distraction or osteogenesis. It is also being done to raise the height of the ridge. Somewhat complicated procedure, but at times it has to be done. Prosthetic management. Impression techniques. In patient with severely resorbed ridges, lack of ideal amount of supporting structures decreases decreases the support, and the encroachment of the surrounding mobile tissue onto the denture border reduces the stability and retention both. Thus, the main aim of the impression procedure is to gain maximum area of coverage. For example, in a mandibular ridge, obtaining a fairly long retromylohyoid ridge, mylohyoid flange helps to achieve a better border seal and retention. Selection of proper trace and correct impression procedure is very essential for an accurate impression. Selective pressure technique. This technique is most widely advocated to manage the residual ridge resorption. It makes it possible to confine the forces acting on the denture to the stress-bearing areas. This helps in the better withstanding of mechanical forces induced by the denture wearing. Winklers describe a technique which uses tissue conditioners. An overextended primary impression of alginate is made. Occlusal rims are constructed and the borders are adjusted so that the lingual flanges and the sublingual crest area are in the harmony with the resting and the acting phases of the floor of the mouth by an open and closed mouth technique. 3 applications of conditioning material are used. Each application approximately 3 to 10 minutes. The third and final wash is made with a light body material. This technique results in the impression that has tissue placing effect with relatively thick buccal, lingual, and sublingual crest area borders. Miller used mouth temperature waxes instead of tissue conditioner. The procedure is same. Mucodynamic technique. It is intended to integrate the changes in the shape of vestibules when functional movements are made. A high viscous thermoplastic reversible impression material is placed in the custom tray, then carefully adapted to the residual ridge and held with light and uniform pressure with the functional movements are made. As soon as the entire surface is smooth and the buccal and lingual borders are molded to the outer circumference without any folds, the impression is complete. According to McCott's technique, a light body elastomeric impression is made. Functional impression technique. Selection of denture base. For degenerative ridge patients, there are 3 types of denture bases. A methyl methacrylate resin denture base, a cast metal denture base, or processed resilient line denture base. Cast metal base. Main advantage of this is it is of great accuracy of the fit to the tissue than acrylic denture bases. They may be of gold, chromium, cobalt, or aluminum. Processed resilient and line denture bases. Its greatest advantage is its cushioning effect on the mucosa and its ability to distort and spring back. Indication. It is indicated in patients where severely undercut ridges are present, but for whom surgery is contraindicated. Patients with parafunctional mandibular movements habits, this situation is indicated. Patient with flat ridges and delicate tissue. Limitations. They can be used only under a hard processed acrylic resin base, and the lining works best where there is a minimum thickness of 2 millimeters. Deterioration of the liner in some mount is the limitation of this. Teeth selection and arrangement. Teeth can be selected according to their form and size. Anatomic or cuspal teeth, semi-anatomic teeth, or non-anatomic or 0-degree teeth. The following requirement has to be met during the teeth arrangement: stability of occlusion in centric relation and balanced occlusion for eccentric relation. Monoplane teeth arrangement, that is the 0-degree teeth. Lingualized articulation. Hollow denture option, especially indicated in cases of atrophied maxilla. Reduces the weight of maxillary denture, useful for the patient having severe atrophic maxillary ridges along with increased interridge distance. Hollow denture procedure is very tedious to do, but wherever the results are desired, such procedure has to be done. Another technique is a neutral zone technique. It is made with regards to the equilibrium of labial muscle and the tongue. The denture is fabricated in the neutral zone where these muscles having the forces in equilibrium, so the denture is stable in the neutral zone. Implant support prosthesis. The various problems associated with residual resorption and stability of removal soft tissue bone denture have aroused interest in dental implantology to provide stable mechanical support to the dental prosthesis. Advantages of implant supported prosthesis: maintenance of alveolar bone, maintenance of occlusal vertical dimension. Height of alveolar bone is found to be maintained as long as the implant remained healthy. Improved psychological health. Regained proprioception, increased stability, retention phonetics, maintenance of structure and function of muscles of mastication and facial expression, immune to caries, increased trabeculation and density of bone, overall volume of bone is maintained, efficiency to take up stress and strain. There is 20-fold decrease in the loss of structure with implants when compared to resorption that occurs in removable prosthesis. Preventive implant is given following extraction to retard the ridge resorption. Prosthetic classification of implant supported prosthesis. FP1, fixed prosthesis replacing only crown. FP2, fixed prosthesis replacing crown and portion of root. FP3, fixed prosthesis replacing missing crown and portion of the edentulous site. FP4, RP4, removable prosthesis, overdenture supported by implant. RP5, removable prosthesis, overdenture supported by soft tissue as well as implant. So RP4 and RP5 are the prosthesis being planned for such cases where residual resorption is taking place. The success of implant prosthesis, however, depends on the technical knowledge and mastery of implantology and is directly related to the selection of patient and implant, surgical technique, follow-up procedures, and patient acceptability to the procedure. So to summarize, residual resorption is a chronic, progressive, irreversible, and disabling disease of multifactorial origin. Much is known about its pathology and pathophysiology, but lot remains to know about its pathogenesis, epidemiology, and etiology. Residual resorption requires a multiple approach for diagnosis and treatment planning. The cause must be detected by the aid of physician and then eliminated or stabilized before denture are constructed. Construction of stable functioning denture and a regular follow-up treatment can help in restoration of function and thus the restoration of these physical and mental vitality to the patient. So to conclude, the preservation of supporting tissue is a sacred trust that cannot be ignored. The application of basics, concepts, and advances made in the basic science will help to keep this trust in hands of the dental profession. As a prosthodontist, we need to perform the most meticulous and intelligent prosthodontic care of the patient within our capabilities. And then it would not seem a nebulous hope that someday there will be a control over the residual resorption. Thank you.